Hi everyone, and welcome to another menopause support video. Today I am joined by menopause expert and gynaecologist Nick Panay. Nick is definitely one of our top menopause experts. He runs the clinics at Chelsea and Westminster and at Queen Charlotte's Hospital. And Nick also runs Hormone Health, which is in Harley Street and now also in Nottingham. So Nick, thank you so much for giving up some of your very valuable time to speak to me.
Pleasure's all mine.
It's really helpful. So what we did was I actually asked, so the Menopause Support Network group is around 16,000 women. So knowing that I had a little bit of your time, I asked people what they would really like to know from you. So we had some common themes coming up. So I'm going not to waste our time, but I'm going to crack straight on with the questions, if that's okay with you. So the first thing that comes up really regularly is the theme around the mental and cognitive symptoms of menopause. And that's quite shocking for a lot of women because they've been led to believe that it's hot flushes and periods stopping. So I wondered, Nick, one of the questions we get asked all the time is, why do those things happen? What's the connection between estrogen and the brain? And I wondered if you would be kind enough to talk to us about the importance for estrogen and the brain and what's really going on there and why those symptoms are so prevalent in so many perimenopausal women.
I think that's a really interesting issue, Diane, and it's one which I'm often seeing ladies about because perhaps the symptoms don't present in the classic way of hot flushes and sweats. But I think you'll agree with me that often the mental health symptoms, the emotional symptoms, are in many ways more distressing than the hot flushes and sweats, and interfere with a woman's ability to function personally, socially, and professionally. And often these symptoms appear to go hand in hand with sort of cognitive problems as well. So as well as fluctuating moods or low mood, there's often brain fog as well, which makes it difficult to function up to one's normal level. So the reason this occurs, we think it's genetic. We think that women who are particularly affected by symptoms, particularly these type of symptoms, have a genetic preponderance or vulnerability to be affected by fluctuating hormone levels, which affects their neurotransmitters. And the particularly important neurotransmitters are serotonin. So as estrogen levels start to fall, serotonin levels start to fall or fluctuate, and that can lead to low mood, it can lead to anxiety, depression, but also, and I find that this often goes hand in hand, the women with cycle-related symptoms seem to react adversely to rising progesterone levels in the second half of the cycle, which increases GABA levels, which then has a central nervous system mood lowering effect, a depressant effect. So not only do I find that as estrogen levels fall in the approach to the menopause transition, but those women that are, if you like, genetically more vulnerable to hormone fluctuations that lead to PMS, those PMS symptoms, or in severest form, PMDD, also seem to occur. So you get this sort of perfect storm of cycle-related symptoms and falling estrogen levels, which leads falling serotonin levels and low mood. And we believe that it's this combination of factors that makes it very difficult, and indeed, I would say in some instances inappropriate, to just throw antidepressants at the picture, at the situation, and why these women often do better with hormone therapy, particularly moderately high doses of estrogen delivered through the skin.
Yeah.
And where there is progesterone intolerance, either delivering the progesterone vaginally or using reduced courses of that.
Mm-hmm.
And I find that by stabilizing those hormonal fluctuations, you stabilize the neurotransmitters, and therefore that has an uplifting effect on mental health, a mood elevating effect. Now, there are data from trials showing that estrogen at these moderately high doses, typically 100 microgram patches or 4 pumps of estrogel per day, can have benefit for these symptoms. But we definitely need more research. And I think we particularly need more research to understand why some women are more affected than others. But there's some really interesting work that Peter Schmidt and David Rubinow have been doing, professors at they were at Harvard when they did this research, showing that the hormone receptors in women who are vulnerable to these changes, particularly the estrogen receptor, are coded differently genetically to those women that don't have these vulnerabilities to hormonal fluctuations.
It's really interesting. Nick, how this is not a question that kind of we had discussed before, but sort of off the top of your head, the women that you would see in all the settings where you practice, kind of percentage wise, how often do you think you would, I know that you're generally seeing women who are, sort of probably in the 1 in 4 who are having debilitating symptoms. How often do you think you see these, kind of psychological and cognitive symptoms percentage wise?
I think it's one of those questions that if you don't ask, then you don't necessarily get volunteered the information. But in my practice, I would say over 50% have these emotional and cognitive symptoms if you ask about them. And I would say that in the majority of those that do have them, they find those symptoms at times even more distressing than the physical symptoms and the classic symptoms like hot flushes and sweats.
Yeah, the reason that I ask is because the majority of the women that I counsel, those will be, kind of, they're a sort of, when you ask them, they're their top symptoms. And again, we have to take into account that those women are coming along because they are struggling. They're not the women who are not experiencing symptoms. So we are looking, a specific cohort here. But it's just really interesting, isn't it, that there is still this sort of public perception that menopause is hot flushes and period stopping, when in fact for many people it is the cognitive and psychological symptoms which are the most debilitating and have a significant effect on their quality of life.
One of my colleagues that I trained with, Professor John Studd, always used to talk about the triad of hormone responsive depressive disorders. So this is, premenstrual symptoms, that then that individual is usually well during pregnancy because hormone levels after the first few weeks are high and stable, and then postnatal depression or postnatal blues. And then as the menopause approaches, perimenopausal depression, all in the same predisposed individual. And I think that model, still stands true today, that we believe is a very good way of ascertaining whether somebody has that hormonal vulnerability, if you like, but they were well until their period started. They may have had a really bad time also as adolescents, because we know that that's another time when hormone levels fluctuate. And I see, sort of young women in my practice who are really struggling at school. And then once you stabilize the hormones, either using the pill or hormone therapy, they do so much better. And then, listening to how they were in the latter half of pregnancy when they're usually well, unless they've got sort of ongoing morning sickness. And then the sort of blues postnatally, as the placenta separates and you get loss of those hormones of estrogen, progesterone. And so in those women in whom we were using hormone therapy, for instance, with premature ovarian insufficiency, we were replacing hormones, and and then they went on to have perhaps egg donation and a
Mm-hmm.
pregnancy there. It's really important to get those hormones back in early. Or the women that we're treating with PMS that are well during pregnancy, again, really important to get back in with those hormones as early as possible. And we can use the hormones during breastfeeding as well. Once the breast milk has come down, there's no reason why that can't be given. No harm to the baby, as long as we use the bioidentical type hormones.
Yeah, I mean, I remember reading the paper that you and Professor Studd wrote, Nick, about sort of about postnatal depression and hormones, and the connection there. What's your thought about not specifically around those women who have experienced PMS or POI in the past, but women more generally? What's your thought about kind of the drop in estrogen when the baby has been delivered, and about whether or not there should be a conversation around estrogen being more widely available to those women?
Well, this is where we need better collaboration between gynecologists, obstetricians, psychiatrists, and psychologists.
Yeah.
Because I believe that this is an area that isn't given sufficient attention. And these women often do end up on antidepressants, and hormones aren't considered. And there was a very good study performed by Alain Gregoire with collaboration from Professor Studd, Professor Kumar at King's,
Mm-hmm.
many years ago now, that really needs to be replicated. And that study showed clearly the benefits of postnatal use of estrogen to treat depressive symptoms. But until we start to do research again within that area and get licensed options, I think and use of psychoactive medications is going to predominate. I'm not saying that estrogen is the complete answer.
No.
But it should be part of the
armamentarium. It should be a consideration.
That we use.
Yeah.
Absolutely.
And Nick, when we're talking about this kind of paucity of research or the lack of research, are we talking about just the finances being available for that?
It's partly financial. I think also it's partly because of the lack of collaboration between gynecologists and psychiatrists.
Yeah.
And I work closely with Michael Craig, who runs the psychoendocrine clinic at the Maudsley, which is a fairly unique clinic.
Yeah.
And Michael describes himself as a gynecologist because he also sort of qualified in gynecology as well. But we need more people like Michael to collaborate with.
Yeah.
I'm going to keep working with Michael and other psychologists, psychiatrists, so that we can improve the situation with regards to what's on offer to women in those situations.
Yeah, it's fantastic to have those collaborations, isn't it? So Nick, the next thing that, as I said, comes up regularly is around the hormone estrogen, and questions around, could you sort of talk to us about why estrogen is, bearing in mind that majority of women are postmenopausal by the time they're 51, 52, why is estrogen so important for long-term health?
Well, estrogen is important for short-term, medium, and long-term health.
Yeah, okay. So I was taking it for granted for the other two.
The reason I say that is because we need to talk about, and I want to talk about that sort of immediately, urogenital health.
Yeah.
So vaginal atrophy, bladder symptoms, etc., which are often neglected.
Yes.
And these sometimes occur early on, but usually sort of occur in the medium to longer term. But we know that if we look at the totality of postmenopausal women, over 50% suffer with symptoms as a result of the loss of estrogen in the vagina, which leads to thinning of the epithelium, loss of lubrication, loss of elasticity, but also thinning of the urethral and bladder lining, making the nerve endings more sensitive so that women get these feelings of having to rush to the loo all the time, getting up in the middle of the night, but making them more vulnerable to urinary tract infections. So we're seeing women getting repeated courses of antibiotics when in fact a little bit of vaginal estrogen will do the job better because it's preventive. And we know that 1 year of vaginal estrogen is equivalent to about a day of HRT. So in those women that are worried about using systemic hormone therapy, we can at least sort of say, well, use the topical treatment because that really is not getting into the circulation. So that's the first thing to emphasize. The second thing is the importance, of course, of estrogen and bone bone turnover. We know that bone turnover, and particularly bone breakdown, increases as women lose estrogen. So replacement of that means that less bone turnover is slowed down. The rate of bone formation is equivalent to the rate of bone loss, and so bone loss is stabilized. And we know that women reach their maximum bone density, peak bone density, usually in their late 20s or early 30s. And it's interesting how it sort of mirrors the reduction in ovarian reserve, which starts in a woman's 30s, that sort of gradual sort of loss of bone density, which then accelerates through the menopause and beyond. And also what's really interesting is that cardiovascular health, which is another important aspect of women's health that estrogen influences, there's evidence that blood fats and insulin resistance starts to kick in as a woman's ovarian reserve again starts to drop mid-30s onwards. And again, potentially, if left unchecked, can lead to an acceleration of cardiovascular health, cardiovascular conditions, cardiovascular problems, which start to mirror the incidence of male cardiovascular incidents, coronary heart disease, etc., from 50s onwards. And I think one of the things that there's been perhaps a failure to recognize is that women presenting with cardiovascular symptoms may not present in as classic a way as men do, with crushing central chest pain. And we have to be aware and mindful that women in the menopause and beyond are just as vulnerable to heart disease as men are, even though we may suffer with those problems earlier. Now, the other thing for which there's been quite a lot of controversy about is the importance of estrogen and dementia.
Yes,
and
I was going to ask you what your thoughts were on this.
My belief is that the potential protective effects of estrogen, which we talk about this window of opportunity for preventing cardiovascular disease, if we start estrogen early, because of the beneficial effect it can have on blood vessel elasticity, on making women more insulin sensitive, on the lipids, lipoproteins, etc. Potentially there is that window of opportunity as well to prevent dementia if estrogen is started early enough, because the blood vessels in the central nervous system and the deposition of amyloid, which has a deleterious effect on the communication of the neurons in the central nervous system, is not yet established. So you can achieve the benefits of improving blood flow, improving the connection of the neurons, which has been shown, estrogen has been shown to have a trophic, a beneficial effect on connectivity of the neurons within the central nervous system. That can all be achieved early. So, but if you leave it too late, as they did with the Women's Health Initiative study, when the blood vessels become hardened and inelastic, and you've lost a significant amount of grey matter already, then of course estrogen is fighting an uphill battle. And if you're giving too high a dose of estrogen that is taken orally, so it increases the risk of clots, then you potentially can make things worse, because you block off the blood vessels to the grey matter, as you do to the myocardium, when you give too high a dose of oral estrogen in women who have established coronary heart disease.
Nick, when you
So,
talk about that window of opportunity, could you just
yes.
explain what you mean by that?
So we believe that if you start hormone therapy before the age of 60 or within 10 years of the menopause transition, then there is the opportunity to achieve heart benefits, potentially brain benefits as well.
Mm-hmm.
But if you start too late, when the blood vessels have got atherosclerosis, they become hardened, they've got deposition of what we call plaque, so they become thickened and narrower, then it's too late to influence the vascular system by then. The problem that we have, particularly with dementia, is that you're looking at using something now to try and prevent something that may happen 20 or 30 years from now. Therefore, it becomes a very difficult thing to prove in the traditional sense of doing randomized trials.
Yes.
So there is this argument that the women that do well with hormone therapy in terms of their heart disease and dementia are doing well because, you know, they're a healthier population that are using it anyway. So it's difficult to control for these, what we call confounding variables, for these variables that, unless you do a proper prospective randomized trial, giving women active treatment or dummy treatment for many, many years, then you can't, you know, make sure that women in both sides of the equation are equally healthy or equally unhealthy to begin with.
Yeah. No, absolutely. That totally makes sense.
Can I just add one more thing?
Yeah, sure.
The window of opportunity doesn't apply to the same extent with bones.
Okay.
So one of the beliefs out there is once you've lost a certain amount of bone density, you can't get it back.
Okay.
But we know that with appropriate doses of hormone therapy, you not only prevent bone loss, but you can increase bone density as well. So as far as osteoporosis is concerned, it's never too late to start hormone therapy.
Right.
But that's not to say that we should use hormone therapy as first-line treatment over the age of 60. So the regulators and the menopause societies are very clear that alternatives to hormone therapy should be the first line of intervention if you've got somebody who needs, you know, treatment for osteoporosis in their 60s onwards. But if you've got somebody with menopause symptoms that might benefit in other ways, and you are careful about the dose that you use, perhaps using it through the skin rather than orally on that occasion, so you don't increase the risk of thrombosis, then you can increase bone density and prevent fractures even later on. Okay.
So, Nick, you've mentioned dose a few times, and one of the things that I get asked on a very regular basis is two-part question. One is, how do I know? You know, kind of, how do I know what dose I can have? How do I know when it's right? So that's more simple. But then also, a lot of women are told, you know, for instance, they're on a 50 microgram estrogen patch. They're still symptomatic, and they're told, no, that's, you know, kind of, that's a high dose. Could you talk a little bit? And I know that you can't talk about you know, I know that you have to talk very generally, but could you talk a little bit about the kind of how to, as a woman, how do we sort of, we can't titrate our own doses, so how do we kind of get the right dose? But also, we often get asked, well, you know, doctors talk about numbers, particularly menopause specialists, like if you're postmenopausal, what is the right level of estrogen? And I know there isn't going to be a single answer to that, but could you kind of talk a little bit around that?
Okay, so I think the key to success is individualizing. And I always say, first treat the patient, not the result. So the best judge of whether a hormone therapy is working and is the right dose is that individual has full alleviation of their symptoms without any side effects. So if you've got that, then you don't really need a blood test to tell you that you're on the right track.
Yeah.
A blood test is helpful, I believe, where you've started somebody. Okay, so the current thinking is it's better to start with lower doses.
Yeah.
And then increase the dosage if required to achieve the full benefits. In the past, we used to start with doses, I think, that were too high. That would lead to side effects and potentially put people off from using their hormone therapy because of those side effects.
Okay.
So also potentially risks are greater with a higher dose. So we try to achieve the benefits with the minimum effective doses. But I have to emphasize fully effective doses. So what we do is we start with a modest dose to begin with, and review the situation usually at around 12 weeks because you expect the maximum benefits by then. If that individual is still experiencing symptoms, I might do a blood test to see if the levels are low, or I might say, okay, well, let's go up in dosage. You're not on a particularly high dose to begin with. Let's see if the next step up fully controls your symptoms. If I start somebody on a dosage and they come back and they say, oh, I'm experiencing nausea, breast tenderness, fluid retention, just feel uncomfortable. To me, that sounds like the dose of estrogen is too high, and I will then reduce the dosage. And again, I might do a blood test to look at those estrogen levels.
Yeah.
But I think you hit the nail on the head to say that there isn't an absolutely right level for everyone. And that's where I think in the past we've been going wrong, that there hasn't been sufficient individualization of treatment. And that's where I think people who are more experienced in managing women with menopause symptoms are able to titrate the dosage to their precise requirements. We may not get it right the first time, you know.
It's treatment, not magic.
Yeah. But as long as, you know, we explain what the potential side effects and risks might be, as long as we explain that we may not fully alleviate the symptoms to begin with, but we're doing this to achieve the benefits as safely as possible, then usually you keep, you know, that woman on board with you on that journey together.
So Nick, you and I have spoken in a previous video specifically around menopause and cancer and HRT potentially after particular types of cancer. I just wondered if you could just brief a couple of things that come up a lot are women who have fibroids and women who have active endometriosis, who are often, you know, kind of blanket told, no, you can't have HRT. Could you just talk about whether or not they can, and if they can, how that should be, you know, how that should be dealt with?
Sure. So fibroids, well, neither of those conditions, first of all, are an absolute contraindication to hormone therapy. We should be more cautious in how we prescribe the hormone therapy, but no, there's no reason why women with those conditions cannot still be considered candidates for hormone therapy. Now, with fibroids, what I find is that if you keep the doses of hormone therapy on the lower side, then it tends not to stimulate fibroid growth. I think the problem is where a woman perhaps requires higher levels of estrogen to control her symptoms, and then you have to be careful about monitoring the fibroids to make sure that they're not growing.
Yeah.
So I, you know, in those situations, I'll recommend that they have a scan a couple of times a year to check on the fibroids, make sure they're not growing. In my experience, if you keep the doses relatively low, 9 out of 10 women with fibroids don't find that the fibroids will grow. One of the things I would say about fibroids, though, is that if you've got a fibroid that's sitting inside the uterine cavity rather than on the outside, they are more likely to cause bleeding problems. And we would normally advise that those fibroids are removed. And the removal is usually fairly straightforward. It can be done with a telescope inserted into the uterine cavity and the fibroid scraped away.
Mm-hmm.
So no cuts have to be made in the tummy or anything. But other fibroids can be left where they are and just monitored.
Okay, great. Thank you.
With regards to endometriosis, again, it depends on the severity of the endometriosis. Mild to moderate endometriosis doesn't usually cause a problem. Severe endometriosis can be an issue. And again, if you use a dose of estrogen that's too high, you can certainly make endometriosis symptoms worse, or endometriosis can return after it's been dormant for a while.
Mm-hmm.
So again, it's about achieving the benefits with the minimum effective doses. I think the balance of estrogen to progesterone is vitally important. You need to make sure that you're giving enough progesterone to not only protect the lining of the womb, which is primarily why we give it, but also to prevent resurgence of the endometriosis. And ideally, you want to give the progesterone continuously without a break, rather than regenerating the cycle with cyclic HRT, which is more likely to trigger the endometriosis. And if you've got somebody after hysterectomy who we traditionally would not give progesterone to, if they've got moderate to severe endometriosis, I normally do recommend progesterone as well, not only to prevent recurrence of the endometriosis, but there are these rare sort of tumors that can occur in endometriotic deposits if they've been stimulated for a very long time without the presence of progesterone.
Okay, fantastic. Thank you, Nick. And talking of...
Just a final thing to say. This is where the intrauterine systems, Mirena, for instance, the levonorgestrel systems are very good. Can help with fibroids, but particularly with endometriosis. Very good because the hormone is delivered where you need it, and it seems to be a very effective way of keeping the endometriosis suppressed.
Nick, on the subject of Mirena, could you just tell us, for HRT, as part of an HRT regime, what's the what's the length of time that a single Mirena can be used for?
Okay, well, strictly speaking, the license in the UK is for 4 years, but everyone, including the Faculty of Sexual Reproductive Health, RCOG, etc., is very happy for the Mirena to stay in for 5 years to protect the uterine lining when using it with estrogen. And in the rest of the world, it's 5 years.
Great.
So it was just a quirk of the data that were submitted to get the license in the first place, that they weren't right up to the 5-year mark. And so there was initial caution. But actually, there's evidence that Mirena continues to release progesterone even in year 6 and 7. And although we don't recommend it as ongoing protection of the lining on its own in years 6 and 7, there isn't that sort of urgent, right, it's 5 years now, I've got to change it in the next 5 minutes. Otherwise, something horrible is going to happen, or the Mirena is going to go off or something. And we know that Mirenas can be left in for much, much longer than 5 years in women in their late 40s, early 50s, going into their mid 50s, when they can then have it taken out if they're using it for contraception or just control of bleeding problems.
Okay.
There's a couple of new systems, new kids on the block.
Right.
Which one's called JDES, the other one's called Kylena, which are lower dose systems, which are currently only licensed for contraception, but with monitoring in our unit, and I'm not recommending this, in the general population, but with monitoring in those women who are progesterone intolerant, then we've had some good results using those systems, monitoring the lining to make sure that women are getting enough protection. Again, that needs better research, needs more research.
Yeah. And you lead on beautifully, thank you, to my next question, which is around why...
Which I didn't know what it was.
Why do some women seem to struggle so much with sometimes, you know, you mentioned earlier PMS, PMDD, sometimes with their own natural hormone levels, but when HRT is given, why is it that some women really seem to struggle with progesterone?
Again, it's probably genetic vulnerability, and it seems to be the same group of women that suffered with premenstrual syndrome or PMDD that are often progesterone or progestogen intolerant.
Mm-hmm.
It's usually intolerance to the progestogens, the synthetic, not bioidentical version of natural progesterone, which is the problem, although some progestogens are better than others. Dydrogesterone, for instance, is very similar to natural progesterone,
Yep.
and usually better tolerated. And we know that, again, in the central nervous system, where natural progesterone can have a calming effect, a mood settling effect, if you like, synthetic progestogens stimulate the progesterone receptors in a different way. They, if you like, they aggravate the progesterone receptors. They make them irritable.
Mm-hmm.
And so they can have a very different effect. Now, for those women who are intolerant to even natural progesterone, using the progesterone vaginally rather than orally can be of benefit, because when you take progesterone orally, it's converted to allopregnanolone. That can be beneficial to some women who are looking for a calming effect, but for others, it can have a mood lowering effect.
Mm-hmm.
You don't get that conversion if
With
the
vaginal.
progesterone is delivered vaginally. Yeah.
And Nick,
On the other hand, for women who need help with their sleep and they
oral.
take the progesterone orally, you know, it's more likely to work if it's taken orally.
So Nick, when women use their body identical progesterone, when they use it vaginally, I've been asked, is it more effective to deliver it vaginally for the endometrial lining, because you're delivering it exactly where it needs to go? Is it more effective than oral? And as an effect of that, can the dose be reduced?
So we lack head-to-head studies looking at the protective effect of oral versus vaginal, but certainly if we look at levels of progesterone, they are higher in the circulation if the progesterone is delivered vaginally,
right,
because it goes directly into the bloodstream, particularly around the uterine area, as opposed to orally, where it first has to be metabolized in the liver and then delivered into the bloodstream. So in theory, you could use a lower dosage, but in practice, again, we lack the data to guarantee that.
Right.
But if you're asking me, do I think you can get away with lower doses of progesterone if it's given vaginally for endometrial protection? Yes, I think you can.
Okay.
The same way when we deliver intrauterine progestogen with Mirena, we don't need particularly high doses, and certainly very low doses in the circulation to get very good endometrial protection.
Okay, great. So on to testosterone, which there are always lots and lots of questions around. So could you talk as an overview about what the role testosterone plays in women's bodies? And subsequently, when we go into peri and post-menopause, not every woman will need supplemental testosterone. Some women it's more important than others. Can you just talk about that generally, because we don't often hear testosterone talked about with regards to women's health?
Not enough. And I think you'll agree with me that not everyone knows that testosterone is a female hormone. It's often talked about as the male hormone.
Almost always written about as a male hormone as well.
The other fact that's not known is that women premenopausally produce 3 to 4 times more testosterone than they do estrogen.
Yes.
So it's very much a female hormone. And we know that one of the most important functions of testosterone is that through dopamine in the central nervous system, it modulates sexuality. So not just libido, so not just sexual desire,
Mm.
but arousal and orgasm.
Yeah.
Now, I'm not saying that testosterone levels fall off the edge of a cliff with menopause. They don't,
Yeah.
not through natural menopause.
Mm.
But there is this gradual decline, again, which seems to mirror the decline in ovarian reserve,
Yes.
the production of testosterone from the ovaries.
Mm.
But particularly does fall off a cliff. 50% is lost after surgical menopause,
Yes.
if the ovaries are removed. But as well as the sexuality parameters, we know that testosterone receptors almost entirely mirror the estrogen receptors in the female. So there are testosterone receptors in the brain, in the cardiovascular system, in the bones, in the urogenital tract.
Yep.
So any benefit that you can think of with estrogen, potentially you can also get with testosterone as well. But there are differences, there are subtle differences as well. Testosterone doesn't seem to be in women as important as it is in men in protecting against osteoporosis.
Yep.
And estrogen is more important in women from that perspective. The urogenital tract, we know that testosterone can have a benefit independently of estrogen in protecting the collagen, the elasticity, the lubrication of the vagina, for instance, and the vulval area. In the brain, we know that as well as improving as well as improving sexuality, it can improve mood, it can improve cognitive functioning, and modulates for that very well. And we know that in the cardiovascular system, whilst there have been some concerns about whether testosterone might increase the risk of breast cancer, in fact, some studies suggest that it helps to balance the rate of breast cell proliferation to what we call apoptosis, so programmed cell control, so that there is this balance maintained. So there's a lot that we know about it, but there's a lot that we still need to know about it. So, for instance, in the trials that have been performed, very few studies have been done to look at the impact of testosterone in terms of mood, in terms of bones, in terms of the cardiovascular system, in terms of the urogenital tract. We need to do more research from that perspective to prove what we think from the physiological perspective, that it would be valuable to supplement in terms of those parts of the body. What we can say definitively from the randomized trials that have been done, and I've been working with a collaborative group led by Professor Susan Davis, who's currently president of the International Menopause Society from Melbourne, over 8,000 women who'd been randomized to either testosterone or placebo. We know that from those studies that there is a statistically significant improvement in sexuality, in sexual desire, in sexual episodes, and improvement in arousal and reduction of distress associated with those symptoms, with minimal side effects, minimal. So, no beards and moustaches, a little bit of excess hair growth perhaps, or maybe some spots in those whose levels were a bit higher. The studies did not show an increased incidence of heart disease or breast cancer, but we have to accept that we need longer term randomized trials to prove that definitively. So cutting a long story short, I think testosterone should be offered to women alongside estrogen and progesterone when we're talking about hormone therapy. But as you know, what we lack are licensed options, not just in the UK, but globally.
Everywhere,
So we're having to use titrated down doses, 1/10 of the male dose to achieve a physiological female dosage. So we're telling women to make a sachet of testosterone gel for male use or a tube to last 10 days rather than use it daily. Or the pump dispensers, use them every other day or every 3 days rather than daily. It's not ideal.
No.
We do have a product called Androfen, which is indicated for female use, but has to be imported from Western Australia, and is not available in every pharmacy, is not available to prescribe on the NHS.
Yeah.
So it's far from an ideal situation until we get those products, until there are licensed options and people feel comfortable using those. Then I think women are not going to be offered it regularly.
Yeah.
And as you know, sometimes it can be the missing ingredient.
Oh, it absolutely. Personally, as you know, yes, it absolutely, for me, after surgical menopause, absolutely was. It was as if somebody had removed a chip from my brain and then you prescribed it back for me. And within a few weeks, it made a huge difference. Absolutely huge. Just briefly, could we just talk about particularly the younger women, the surgical menopause, the POI women, and how important testosterone potentially is for those women?
I'm glad you brought up the issue of POI, because POI, premature ovarian insufficiency, which is the sort of technical term, if you like, for premature menopause, is going to be the main subject of World Menopause Day for the International Menopause Society. And we've produced a position statement for that. And we're going to have patient materials, women's materials as well to disseminate. We're working with DAISY Network, which is the Premature Ovarian Insufficiency support group that I'm a proudly patron
They're a
of.
brilliant charity. They're fantastic. They do amazing work.
And we know that hormone replacement in women with POI is so important, because it's not just about maintaining quality of life and alleviating symptoms. It is about reducing that risk of heart disease, osteoporosis, dementia, etc.
Yeah.
And that hormone therapy should be used at least until the average age of the menopause. Now, with surgical menopause, we've said 50% of a woman's testosterone levels are reduced. The other 50% comes from the adrenal glands. With POI, even if it's natural POI, we know that testosterone levels are lower in that group as well, compared to sort of age-matched non-POI controls. And so it is a very important hormone to consider, particularly in that age group. And it may be important not only from the sexuality and maintaining the relationship perspective, but there's also some evidence that it helps in terms of if there is any ovarian reserve remaining, creating the optimum environment for any remaining eggs to be ovulated.
Ah, really? How interesting.
And although fertility is hit very hard by POI, and chances of pregnancy are reduced significantly, if we can at least optimize the hormonal environment, that gives the best opportunity for women to try to achieve a pregnancy with their own eggs before moving on to donor eggs, for instance, as the more reliable way of achieving a pregnancy. And we know that egg donation is not for everyone, so I think it's important that we optimize the environment as much as possible for that individual, give them the best possible chance.
So for women who are in a natural menopause, Nick, so let's say you've got a woman who's 45, she started on estrogen and progesterone, she still has her womb, and she's been on it for 6 months, and then she's still experiencing issues with libido, with cognition, with her sort of her outlook, etc., which we know that testosterone can help. For that woman to if she's in front of a doctor or a specialist who can potentially prescribe her, how should testosterone be monitored? Is it monitored in the same way as sort of maybe an annual appraisal of your HRT, or should testosterone levels be checked more regularly to see kind of that they're being kept at optimum?
Yeah, I think the first thing to say is that I try to avoid sort of fancy terminology in these interviews, but we need to have a sort of biopsychosocial approach, don't we, to these situations. So we've considered whether there are relationship issues, whether there are other medicines that may be interfering with libido. Antidepressants, for instance, are potent.
Yeah, absolutely.
The pill. Because we know that estrogen from the pill increases the levels of the SHBG protein, sex hormone binding globulin, which then can mop up free circulating testosterone. And actually, that's the other thing to say, when HRT is being used, it's much better to use estrogen through the skin rather than orally if there's low libido.
Yeah.
Now, when we're monitoring the levels, although we do a baseline level, it's really not to say you've got a low testosterone level and therefore that's why you need testosterone, because sometimes people with low testosterone have got perfectly normal libido, and they don't need to have it replaced.
Because it's complex, isn't it?
Yeah, absolutely. John Studd always used to say heart, head, and hormones, as the covering all that biopsychosocial approach. But we check it so that when we then recheck it, first of all, we can see, has there been a change, an improvement in levels? If there hasn't, then maybe one of the reasons that that person's libido remains low is because the levels have not gone up. But also to make sure that we're not giving too much. So if you have somebody who has normal or high levels to begin with, then you don't want to give them more.
Yeah.
That is more likely then to lead to excess hair growth or spots.
Yeah.
In the consensus statement that we drew up, we said that ideally levels should be checked by 6 weeks on treatment, but realistically, we see women after we start treatment within 3 months, and I think it's reasonable to do it at that stage. And then I will typically check it again after 6 months, and then usually 6 months after that, and then depending on how stable things are, an annual assessment may be sufficient.
Yep.
If you go by the consensus, it says check it a couple of times a year. But I think as long as you know that the levels are stable and you're doing that annual review, I don't think you necessarily need to do a 6 month visit. But it's all about individualizing, isn't it? It's all about working out, right, are things absolutely perfect, in which case, there's no need to monitor as intensively. Otherwise, let's do it more often and make sure that we're not giving too much or too little. But in terms of duration of usage, we make the same assessment as we do with estrogen and progesterone, whether we continue with testosterone long term.
Okay, great. Now, talking about, I've got a few final questions for you, Nick, in the last few minutes we've got together. So one of them, you talked about duration of use. So what comes up all the time is women very happily settled on their HRT regime and then told they can only have it for X amount of time. So could you just I know it is quite a brief answer, but could you just quite briefly talk to us about what the current thinking is around duration of use of hormone replacement therapy?
Well, very simply, we should not be putting arbitrary limits on duration of usage. It should be individualized. There should be at least an annual reevaluation of pros and cons, risks and benefits. Do we need to change the regimen? Do we need to change dosage, et cetera, et cetera? And for some women, they may never need hormone therapy. For others, may need to be on it for a whole lifetime, depending on whether those symptoms are continuing. And we know that in 5 to 10% of women, the symptoms can continue into their 70s, 80s, and even 90s.
Yeah.
Now, I've got a couple of 90-year-old women, that I've looked after in the past. So we should not withdraw it for the sake of withdrawing it. And the limits that we placed on it before were really very arbitrary, 5 years or 10 years, et cetera, which were not based on an awful lot of science. It was more to do with statistics, and when something became statistically significant, which did not necessarily mean that there was no risk before and that the risk is suddenly going to go up exponentially. Yeah. It's just that that was the time that we decided was the key point for analysis, according to the data that we had in that particular study. I think the bottom line is, I have a chat with my patients and say to them, right, are you still benefiting? Do you feel from the hormone therapy in terms of your symptoms? Are there other reasons why you might be benefiting from it in terms of your bones. Look at the cardiovascular risk. Look at family history as well of osteoporosis, cardiovascular risk, dementia, etc. And then look at risk factors such as breast cancer. Are they in a higher risk group? And then we make a balanced choice. And if they say to me, well, I feel fine, but how do I know whether it's because I'm on the HRT or whether it's because I would feel fine anyway? And that's where I say, well, there's no need to immediately come off, but if you did want to test the water, if you did want to try reducing the dose a little bit and seeing how you feel, then we can see, whether you still need it or not. So, that's the way we do it. And it's very important, actually, that we don't stop treatment abruptly, because there are some data from the Finnish, a large Finnish study, showing that women coming off their HRT seem to have initially an increased incidence of cardiovascular disease. So we think, although it needs to be proven, that if you come off more slowly, it's less of a shock to the system.
Right, that makes sense, doesn't it?
Yeah, absolutely. Although, as I say, that does need to be proven, that coming off more slowly, but certainly it does also lead to less rebound symptoms if you come off more slowly. But at the same time, if that person wants to continue, and they say, look, I'm still working, I'm still teaching, or I'm still doing this or that, I need to have all my faculties about me, then, right, well, this is not the right time for you to test the water.
Absolutely. And, there also should be an element, there should be patient choice involved in this, shouldn't there? This should be a conversation between clinician and their patient. It shouldn't be a straight yes or no, should it?
It's totally about patient choice. What I'm here to do, what you're here to do, is to give them the information, the facts, so that they can make an informed, evidence-based choice.
Exactly.
Ultimately.
Yeah. Nick, just going on from length of use of HRT, something that I guarantee you comes up every day is the use of, you spoke earlier about 50% of women plus experiencing vaginal symptoms, as they age. And something that comes up all the time is conversations, particularly with GPs who are very nervous about giving local estrogen alongside systemic estrogen, or for women who have maybe already had Vagifem, something like Vagifem, talking about having vulval symptoms and wanting to use one of the creams alongside that. So you spoke about the tiny doses. And also for those vaginal symptoms, they will need to be managed long term. You said how tiny the doses are. I mean, for me, that it doesn't make sense to not to allow these women to have these treatments. And from everything you've said, there's no medical reason as far as risk versus benefit of why they shouldn't be using vaginal estrogen alongside systemic estrogen and long term.
Well, vaginal estrogen, or vulval estrogen for that matter, the benefits only last for as long as it's used. And I believe, there's such low doses and there's so little concern about long-term use. I would be perfectly happy for somebody to use it for life, and I would encourage them to do so, because you don't want the symptoms coming back 5-10 years later or whenever. And the symptoms will usually return when the treatment is discontinued. And the doses are tiny, as I've said before. 1 year of that particular preparation, Vagifem, is equivalent to 1 day of hormone therapy. So when you're adding such a tiny dose to systemic hormone therapy, and particularly now when we're using perhaps not as high doses of systemic hormone therapy, so it doesn't fully alleviate local symptoms, you're not adding significantly to the total dosage of estrogen. So I have no concerns at all about local estrogen being used with systemic hormone therapy. And in fact, one of the advantages if somebody is on systemic hormone therapy is that they're on progesterone as well as estrogen. And if they're requiring higher than licensed doses of the local treatment to protect the vulva and vagina, then you don't need to worry about the uterine lining at all, because it's protected by the progesterone that they're using systemically.
Yeah.
But I would like to say something about doses, because we now know that because these doses of local treatment are so low, often the standard dose isn't sufficient to fully alleviate symptoms.
Mm-hmm.
And again, I always say, if you're going to be on something, you should be on something that fully alleviates your symptoms, not just, improves things by 20 or 30%.
Yeah.
So often we do have to use more than the standard doses, either more frequently or a higher dosage. Yes, that should be perhaps monitored a bit more closely. But what we have found is that there's not usually a problem, and as you've said, and this is very important, sometimes the vaginal preparation isn't adequate to alleviate the vulval symptoms. So, the itching and the irritation is still there, or there may be particularly exquisite discomfort at the entrance of the vagina.
Yeah.
And I find that if a little bit of cream is just applied to those areas and just sort of carefully massaged in, it can actually make a big difference to the symptoms, as well as applying those vaginal tablets or vaginal creams into the vagina. Again, that's where fine-tuning the treatment to the needs of the individual can make such a difference to quality of life.
Absolutely. And that's really the key, isn't it, Nick? It's about improving, all this is about improving quality of life, isn't it?
Yes, absolutely. And
I've got three.
And enabling women, I think, to take control of their lives. I just get very frustrated that for every person I see in my clinic, there's probably another 100 out there that don't know where to turn and are suffering in silence.
You and me both, Nick. Right, I have three more questions. Have you got time?
Of course. Yes.
Bless you. Thank you. HRT and thyroid medication, women who are on both. Could you just talk a little bit about whether or not HRT has any influence on thyroid medication, or the other way round? And just for those women, because we do have quite a lot of women who are on both now, and about monitoring for, for their medications.
Well, we've talked about sex hormone binding protein.
Yeah.
Another protein which is important, particularly in terms of binding thyroid hormone, is albumin. And so when women are using oral estrogen particularly, or higher doses, there is a potential change in the proteins that bind the thyroid hormone. And we know that bioavailable hormones are the ones that are free from these proteins. So it may be that the dosage of thyroid hormone when somebody goes on to hormone therapy may need some adjustment. So it's important that that's monitored, symptoms are monitored, and it's important that the free hormone is looked at rather than the total amount of hormone.
And is that with transdermal and oral HRT, Nick?
It's more of an issue with oral, but it can even happen with higher doses of transdermal as well.
Okay. Perfect.
Another example of this is in pregnancy, for instance. Often we have to adjust the doses of thyroid medication in pregnancy, again, because other hormones are influencing the binding. The other thing I should say about thyroid hormone is that, we've talked about symptoms in the context of ovarian hormones.
Yep.
We mustn't forget that there's quite a lot of overlap between thyroid hormone, particularly thyroid deficiency symptoms and menopause symptoms. So I think it's really important that the thyroid is monitored as well as the other hormones, where particularly there is persistence of symptoms. And I get a bit frustrated where sometimes you see people with borderline thyroid values, so feeling persistently tired, a little bit sort of weight gain, feeling the cold and whatever, and perhaps are not given a trial of thyroxine, just a low dose.
Yeah.
It might only require 25 micrograms to see whether that helps or not. But that's subject for another
Another video.
Another discussion. Yeah, absolutely.
Okay, penultimate question. Nick, would you give us a brief update on the most recent data that we've had with regards to the WHI? Came out in July, I believe. Is that correct?
I mean, yeah, in the short time we've got, basically, this was a 20-year review of the data. And it was very reassuring that it confirmed, first of all, what we originally thought, that estrogen on its own does not increase the risk of breast cancer, and in fact, probably reduces the risk of breast cancer.
Yeah.
But we have to be cautious because they were using a particular type of estrogen, which is conjugated estrogens, which is the mare's urine. It may behave differently to the 17-beta estradiol.
Of course.
But also there was an evidence that it reduced breast cancer mortality as well, which was good. On the other hand, estrogen with progesterone, there was that small but significant increased risk of breast cancer. But, I always say, put it down into absolute numbers, less than one extra case per 1,000 women per year in terms of incidence. But importantly, with estrogen and progesterone, there was no increase in mortality, breast cancer mortality.
Mm-hmm.
So why are these data important? We had the alarm from the collaborative reanalysis from Oxford of the observational data, prospective and retrospective observational data. This is a very long-term follow-up of what was originally a randomized trial, a gold standard study. So although there were limitations to that study, I think the fact that it was randomized, I think the data are important and compelling, and it means that we really need proper randomized trials in the future to prove this question once and for all of whether HRT with more modern types of regimens genuinely does increase the risk of breast cancer or not, and whether the difference lies in the types of hormone therapy that are used, and we need to be able to exclude variables such as gathering data from breast screening services where potentially women who are going along for breast screening are there because they might have had a higher risk of breast cancer to begin with because of family history or because they've had other breast symptoms or whatever. So I think it's really compelling new data, and I keep saying this, we need the definitive prospective randomized trial. We'll probably never see it because it's going to cost a lot of money and need many, many thousands of women, but I'm going to keep fighting for it.
Fantastic. Great. Right. Last question, Nick. Is there anything new coming on the horizon with regards to treatment for menopause?
Yes, one of the frustrating things about COVID is our clinical trial program has been brought to a temporary halt.
Right.
And we want to restart it. So in terms of hormone therapy, we are in the process of looking at a type of estrogen called estetrol, which is manufactured by the fetal liver. So it's produced during pregnancy. And this particular type of estrogen appears to have similar benefits to normal sort of adult human estrogen, estradiol, but in laboratory studies suggests that it has a protective effect on breast cells. So it prevents the formation of tumors. So it potentially could have a protective effect against breast cancer risk.
Wow.
So that's going to be a very exciting new molecule to research, not only from the point of view of alleviation of symptoms, but also potentially having a breast protective effect. The other studies that we've been involved with are with a group of non-hormonal products called the neurokinin receptor antagonists.
I remember you talking about that, yeah.
Yeah, so these are molecules which block the receptors in the central nervous system, which we think are leading to the generation of hot flushes and sweats. And by doing so, I think providing an option potentially for women who have, malignancies, hormone receptor positive malignancies like breast cancer, for instance. And unlike the other preparations that we've used in the past, which are non-hormonal, that have taken the edge of symptoms and given us some relief, this really is up there with HRT in terms of the degree of effectiveness.
Fantastic.
I think in terms of the brave new world, and the thing that will enable us to truly individualize treatment, it's got to be pharmacogenetics. So looking at someone's genetic blueprint, and then designing a recipe, a hormone therapy recipe, precisely according to their specific blueprint. And then there won't be all this sort of, well, we'll start with lower doses and work up. We'll know exactly what dosage and what treatments to use in each individual case.
Well, I shall look forward to speaking to you more about that. Significantly in the future, I suspect.
So will I.
Nick, Jen, I cannot thank you enough for not just taking the time, but also extending the time. It will be hugely beneficial to so many women. So, thank you for your time. Thank you for your work. It's been an absolute pleasure to spend just over an hour with you again. And I hope at some point in the future, you might consider doing it again.
Thanks very much, Dan. It's always a pleasure.
My pleasure. Thank you so much. Thank you.
All the best.
Bye-bye.
Bye.